Okay, we'll move on to bladder cancer and several issues that we'll try to address. First, actually, we're going to address muscle invasive disease. As you know, staging, it's T2 through T4A disease, and we'll cover a couple issues with regard to these. One will be the issue of neoadjuvant chemotherapy. This is a meta-analysis on neoadjuvant therapy. You'll see in the bottom left-hand corner here, actually, that the hazard ratio for neoadjuvant cisplatin-based therapy in the appropriately selected patient is beneficial in terms of survival. These are the survival distributions for this 3,000 patient meta-analysis showing that there is a benefit. And what drives most of the benefit here are actually two studies at the bottom. It'd be the CMV study and the MVAC study. This CMV is just MVAC without the adriamycin. And two interesting studies. The European study is the largest, close to 1,000 patients. Patients got CMV times 3 cycles, followed by best management. And best management could include radiation therapy or a cystectomy for management of the primary tumor. And you'll see here that the patients who got chemotherapy prior to best management did better than the patients who did not get chemotherapy. Hazard ratio is 0.84. And here, if you look at the patients who had just managed with a cystectomy after neoadjuvant therapy, that hazard ratio is 0.74. So robust data in terms of that study. Then there's the American study. This is a SWOG 8710, has a lot of controversy to it. Patients received 3 cycles of MVAC followed by cystectomy versus cystectomy only. These are the hard data. These are the survival distributions. The hard data was that at 5 years there was an absolute difference of 14%. And then buried in the manuscript was that patients who had cystectomy alone, actually the hazard ratio was 1.66, so 60% more likely to die a bladder cancer specific death. And so these are also supportive studies. When you get back to tumor board, the issue that's always raised that these are bimodality treatments. These are data from that SWOG study, actually independently analyzed by Harry Herr. This looks at the quality of the node dissection that's associated with the cystectomy. These are node-positive patients, and these are node-negative patients broken down by less than 10 or greater than 10 nodes in each one of the groups. The bottom line is that the surgical treatment after neoadjuvant chemotherapy is not just a cystectomy. It's a bilateral pelvic lymph node dissection, and it's a quality dissection. And the more nodes, the better. There's actually no upper limit in terms of nodes. And you'll see that in terms of a couple of these studies, whether it's node positive or node negative, and it doesn't matter. There are 4 major databases looking at this. The more nodes, the better. And obviously, this just illustrates that a quality dissection is important. Why is that important? These are data from the United States looking at the number of nodes, and you'll see that over 50% of patients have 3 or less nodes, 40% have no nodes. And so this is really an important aspect in terms of management. The pathology at the time of cystectomy will predict long-term survival. It's a great biomarker, so to speak. In the superior curves here from that randomized trial 8710 of MVAC versus no MVAC, you see any patient who had PT0, no residual disease at the end of chemotherapy or just by the TUR, that these patients did quite well versus anybody who had residual disease. Now this is no disease versus any disease. I'm going to show you a little bit of data that is just coming out that might be helpful in terms of prognosis. So there's very little data. We have a lot of data with regard to MVAC and neoadjuvant therapy, very little data in terms of GC as a neoadjuvant approach. This was a retrospective study at our center looking at the 2 different managements of GC times 4 cycles, 12 weeks of therapy, MVAC times 4 cycles, this was 16 weeks. These are the pathologic response rates. About a quarter of patients were sterilized. Some patients, about a third of the patients have residual disease that's just non-muscle invasive, and then a small number of node-positive patients. And these are survival distributions suggesting that they're comparable. We then did a study. This is another retrospective study that's been submitted for publication, and it actually looks at 154 patients treated the same way with neoadjuvant GC because of very little data for a less toxic regimen. And the observation is the following. One is that this is 4 cycles of therapy. The goal was to get full dose cisplatin and gemcitabine, and in patients either split dose, that is given day 1, 8 cisplatin or full dose cisplatin on day 1 were used, depending on the renal function. 88% of patients received at least 3 cycles. Median number of cycles is 4. You can see the dose intensity is pretty good, about 90% for both drugs. And you can see that the time to get patients to cystectomy median at our center is 34 days. So the patients are well enough to tolerate it in the first place. They actually do pretty well in terms of tolerance to chemotherapy. And these are the data with regard to endpoints in terms of speaking with your patients. So I showed you that the neoadjuvant MVAC said that you had to sterilize the tumor completely in terms of having a good long-term survival. That predicted 85%. So we looked at that exact question and asked, does it have to be complete sterilization, or can you have some residual superficial disease? So these are the patients who had either TA disease or carcinoma in situ or T1 disease. You can see they did very well. And if you group them together, less than PT2, their outcomes are actually excellent. For us, it was 90% long-term survival, this 5-year survival. On the other hand, any patient with residual muscle-invasive or greater disease, that long-term survival is about 37%. So it's a good indicator in terms of the modern era. Like many of these diseases, we're trying to find a marker of sensitivity. This is the SWOG trial that's just ongoing now. It looks at coxin. Coxin is really a molecular signature of chemotherapy sensitive for each chemotherapy drug. And so it was developed for use for a single drug, GEM, and then CIS, and then for each one of these 4 drugs. And this trial actually randomizes in the neoadjuvant setting GEM-CIS versus a dose-dense MVAC, giving 4 cycles at 2-week intervals, and then cystectomy. And the goal of this study is to predict who responds to GEM-CIS and who responds to MVAC. It is not a comparison of the 2 regimens. There has been a review in terms of adjuvant therapy. Why not do the surgery first, just give adjuvant therapy? There are about 600 patients at the time of this meta-analysis, and the conclusion was, of the 600 patients, there could not be a meaningful interpretation of the data. Since that publication, there's been several adjuvant trials that have been published. This trial actually is the Italian trial looking at GC in the adjuvant setting. This trial did not reach its planned accrual, but it's 194 patients. GC had 2 different sequences, either platinum on day 2 or day 15, versus observation and treatment at time of relapse. These are patients with high-risk disease. They had either extravesical, T3, or node-positive disease. And you can see from the survival curves, it didn't matter which of the schedules you received, and it didn't matter whether or not you got chemotherapy. Both the control arms and the chemotherapy arms did equally poorly. There have been 2 other trials, the ERTC trial just presented at ASCO 2014, and then the Spanish trial. Now, the Spanish trial looked at 3 drugs versus therapy at time of relapse. Same types of patients. These are PT3 or PT4 or N-positive patients. They have a long-term survival that is roughly less than 40%. Immediate therapy versus no immediate therapy. ERTC, a little different design. Dealer's choice, any cisplatin-based regimen immediately or at the time of relapse. Neither one of these trials reached their targeted accrual. These are the data. So these are the data for patients who had the 3-drug therapy from the Spanish trial. You can see only about 150 patients that were actually accrued to the trial. This is the survival distribution. Now, this is 3 drugs, GEM-CIS plus paclitaxel, versus no immediate therapy. And I just showed you the Italian trial where these curves are superimposable. So one has to read into this, is this difference in survival related to one drug? And that's hard to believe. And it turns out, actually, that none of these trials are controlled for surgical data. So we don't know, for example, the number of nodes removed, et cetera. And those are really critical for interpretation. This is the BEST trial. This is the ERTC trial. Originally planned for 660 patients. Unfortunately, only 280 patients. Immediate therapy. Any one of the cisplatin-based regimens immediately or at time of relapse. Progression-free survival was improved. As you can see, it's markedly improved, and it's statistically significant here at 0.0001. On the other hand, if we look at overall survival, there's a non-significant 22% risk, a decrease in the risk of death. And as you can see here, that was not statistically significant. I think this is a function of the fact that this is an underpowered trial. This was mentioned earlier by Dr. Nanis and by Dr. Galsky, Sipalusil T. You now all know about this. This is an ex vivo processing of leukocytes against a specific antigen in prostate cancer. This has been tested now in patients with bladder cancer, and this is a HER2 extracellular and intracellular domain. It's as the target, and this is the randomization. This trial should be ready for maturity within the next year. So, standard of care concepts for muscle invasive disease. Cisplatin-based neoadjuvant therapy is the standard of care, provided the patient can tolerate it. MVAC and GC should be considered, and there's no data that adjuvant therapy actually improves survival. So in terms of the metastatic disease setting, this is the best trial of GC versus MVAC, superimposable survivals, with MVAC being a more toxic regimen repeatedly in most studies. The addition of a third drug, GC plus paclitaxel, in the metastatic disease setting has not improved survival in a meaningful way, so GC remains that standard of care. But many patients can't receive cisplatin-based therapy because older patients, obstructive uropathy, intrinsic renal disease. And this is a retrospective study looking at split-dose platinum. Rather than giving it all on day one, why not split it on days 1 and 8? These are the data with regard to the patients going on this study and the reasons for doing it. But let's take a look here. You can see that, at least in this retrospective analysis, that the progression-free survival is 5.4 months. That's very similar to what was seen in the GC trials at 5.8 months, and median survival is 13.4 months. So this is an option for patients in whom you have marginal renal function. What's the next option? And that is carboplatin-based therapy, and it's a step down in terms of efficacy. This is a randomized phase 2, phase 3 trial published by Maria DeSantis, looking at methotrexate, carboplatin, and vinblastine, sort of an MVAC knockoff versus gemcitabine and carboplatin at standard doses here. And these are the survival distributions here. The response rate was greater in terms of the gem carbo patients, 43%. Versus 25%, but you can see that the median survival is around 8 to 9 months, so quite disappointing for carboplatin-based therapy. This is a trial that was looking at the addition of bevacizumab to the GC backbone, and what was interesting in this study by Noah Hahn was that the median survival was 20 months. And most of the studies that we see for metastatic disease are around 13 to 14 months. So this is a stand-up-and-take notice study. And so consequently, a randomized trial was done within Alliance, GC plus or minus bevacizumab. This trial has reached its target accrual of 550 patients in October and is currently under analysis. So we'll know within the next year whether bevacizumab should be included in patients with treatment for patients with metastatic disease. So phase 2 studies of second-line therapy. Not a single FDA-approved drug in the United States for the treatment of bladder cancer that has not responded to first-line therapy. You just saw drugs that were approved for renal cell carcinoma, for prostate cancer, and not a single one for bladder cancer. That's going to change, we think, within the next couple of years. But what's available? Well, NCCN guidelines recommend pemetrexed, a reasonable consideration based on these response rates. Median survivals, you see about 9 months. If you look at the docetaxel group, and paclitaxel, I'm just going to draw your attention here, PRs of 10 to 13%. I'm going to come back to that in terms of some of the immunotherapy trials that we have. And median survivals here of 9 and 7.2 months. And if you happen to live in Europe, they've got this drug called vinflunine. It's a third-generation vinca alkaloid. Median survival is very poor, but it's an approved drug used in some countries in Europe. So we really need new drugs. And so this is from a study done by Gopal Iyer. There's also been, in your handout, is the study from the TCGA. And what we do know is that there are a lot of actionable alterations in patients with in bladder cancer. And this just looks at this particular pathway, the PI3 kinase pathway. And you can see, for example, PIK3CA mutations, like you see in breast cancer, it's 18%, and in bladder cancer, TSC1, 7%. And these are the potential drugs for study in terms of this particular pathway for this disease. And then in the G1S cell cycle regulatory pathway, you can see that there are a number of drugs that could be used for patients whose tumors have mutations of CDKN2A, which is very common, and CCND1. So there are a number of alterations which are actionable, and there are a number of these drugs which are currently under study in terms of this disease. Lastly, the RTK-RAS-RAF pathway. You can see, again, a number of alterations. FGFR3 is the one that's now garnering the most attention. There are several trials looking at this particular mutation, with BRAF and RAF being much less. But you can see a number of drugs that are potential candidates or are in study right now. Why is this important? Well, this is a study of a patient who got everolimus, was one of 2 patients who responded, a major response. She just had her 5th year anniversary of being disease-free, progressed on GC, and then was treated with everolimus, had a complete response, sequenced 17,000 mutations, 140 within the coding regions, and 2, NF2 and TSC1, were cooperative mutations that lent exquisite sensitivity to everolimus, as we can see right here. And it turns out that TSC1 is mutated in a small percentage of patients, and all the patients, or most of the patients who had TSC1 mutations, had at least some biological activity. So this is work done by Gopal Iyer and David Sollett, trying to dissect out the potential for targeted therapy in this patient population. Now, this is from a patient at our center, and so we have 3 different pathways, and we have multiple mutations in the same patient. This really brings up the issue of what we call a molecular tumor board. Which mutation do you choose in terms of your selection for targeted therapy? And this is now becoming a focus of a number of studies, and there actually will be an impact, what's called, a matchup trial by Jonathan Rosenberg, who's the PI for the Alliance trial, trying to align patients who get sequenced, align their particular mutation with that specific drug, and we'll be able to learn collectively which ones are dominating and which ones are driver mutations and which ones are passenger mutations. Why is that important? Well, it turns out, let me go back for a second here if we can go back one. I don't know if we can go back. There we go. So this is a somatic mutation frequencies within a number of different tumors. I'm going to draw your attention here. It turns out that non-small cell, the worst is melanoma, has the highest number of mutations per megabase. And then is non-small cell lung cancer, adeno and squamous. And then the fourth from the top is actually bladder cancer. So these are the tumors that have the highest number of mutations, and it makes sense that trying to dissect out one mutation for a particular drug is going to be difficult. But there's actually data in melanoma that you're going to see that the higher number of mutations, the more likely you are to respond to immunotherapy, and probably because of neoantigenicity. And so we know, as Dave Nannis had pointed out, that bladder cancer does have a long history of sensitivity, or at least recognition, I should say, of immune cells. And this just looks at, for example, muscle invasive disease. If tumors that have more infiltration with lymphocytes at the time of surgery are more likely to survive. And so that's been known for quite a while. So Dave went through the issue of PD-1 and PD-L1. We won't go through that again. PD-L1 is highly expressed in bladder cancer across the board, and this was the expansion study. He's already discussed these two. This trial, this is the Poles trial published in Science. Now, this is anti-PD-L1. This is NPDL-3280. I'm just going to draw your attention again to the response rate. For the patients who are high expressors, high response rate. But if you take a look at the patients who are 0 or 1 expressors, it's a 14% response rate. And I just showed you in second-line therapy with the taxanes, the likelihood of response is around 10 to 11%. And so even in the low expressors, even though we're looking for markers of sensitivity, even in the lower expressors, that response rate looks to be better than what we currently have at the present time. He showed you these waterfall plots. We won't go through them again, but I do think that the swimmers plots are the ones that are really remarkable. That is, these durable responses, and when they start, responders are seen early. This is the Pembro data published by Betsy Plimick and colleagues won't go through this, but the same kind of swimmer plots that you can respond early within a few weeks of treatment, and then durable responses with regard to those that do respond. And then lastly, we'll finish up on the fact that there are a number of these drugs that are in study right now. These are some of the drugs, and these are the companies that are making these drugs. And right now, currently planned within calendar year 2015 are trials encompassing over 2,000 patients with bladder cancer worldwide with immunotherapy. So we're on the verge of a revolution with regard to this disease. So I'll close there. Thank you for your attention.